Imagine an 8-year-old boy. He's vomiting, he has this terrible tummy ache, and there happens to be a massive stomach bug going around his school.
Right, the classic winter vomiting bug.
Exactly. So your textbook says it's just a virus. I mean, it is the most statistically likely answer.
Oh, totally.
But if you ask him to just fold his arms across his chest and sit up and he screams in agony, well, you aren't looking at a stomach bug anymore.
No, you definitely aren't.
You're looking at an appendix that is, like, about to burst.
Which completely shatters that, that comfortable illusion we have of medical diagnosis being this perfectly clean binary process.
Yeah.
We really want medicine to be like engineering. Like a broken bone shows up as a jagged white line on an x-ray. It's visible, it's categorized, and you fix it.
But then you actually step into the consulting room of a general practice and suddenly you realize that X-ray machine is only giving you a tiny fraction of the story.
Exactly, because general practice is where the physical, the psychological, the social, and even the spiritual, they all just smash together.
All in a single 10-minute appointment.
Right. And navigating that kind of environment requires a vastly different skill set than simply, memorizing textbook bullet points.
Yeah, for sure.
It demands an understanding of how diseases actually present when they walk through the clinic door, which is, well, it's very often in disguise.
And that is our mission for today's deep dive. So whether you are a medical student prepping for your rotations or a young professional trying to sharpen your clinical reasoning, or even just a fiercely curious learner who wants to know how the human body actually works.
We are going to be your clinical mentors today.
We are, and we are pulling some incredible case studies from a fantastic clinical textbook called 100 Cases in General Practice.
The overarching lesson in this text is really that deductive reasoning, raw human intuition, and a stubborn willingness to question the obvious are a clinician's absolute most vital tools.
Because that initial symptom a patient presents with, it might have zero connection to the actual underlying pathology.
Not at all.
Let's jump right back to that 8-year-old boy. So this is case 2 from the text. Just put yourself in this doctor's shoes for a second. It's like 7 o'clock on a Friday night in January.
Prime time for wanting to just go home.
Oh, absolutely. A mother calls about her 3 kids. They're ages 3, 5, and 8. They all have vomiting, diarrhea, and abdominal pain. And locally, there is a minor outbreak of the Norwalk virus, winter vomiting disease.
The diagnostic trap there is just almost perfectly laid.
Right.
You have a known local outbreak.
Yeah.
You have multiple family members presenting with identical symptoms, and as you said, it's a Friday evening.
Everyone just wants the simplest answer.
Yeah, the path of least resistance is to diagnose viral gastroenteritis over the phone, tell the mom to push fluids, and log off for the weekend.
But, and this is key, the doctor decides to actually do a home visit, which the text points out is a really interesting balancing act.
Yeah.
Because it isn't always convenient for the doctor, but imposing a car journey on a stressed mother with 3 vomiting children.
Not great either.
No, not at all. So the doctor arrives, examines them, and does that specific physical test I mentioned earlier. He asks the kids to sit up in bed with their arms folded.
Right.
The 2 younger ones do it easily. But the 8-year-old can't. He just moans in pain. So what is the actual physiological mechanism there? Like, why ask them to fold their arms?
It's actually a brilliantly simple test for peritoneal irritation.
Okay, break that down for us.
Sure. So the peritoneum is this silk-like membrane that lines your inner abdominal wall and covers your organs.
Got it.
When you ask a patient to fold their arms and sit up, you're forcing them to use their core abdominal muscles, right? Rather than using their hands to kind of push off the mattress.
Oh, I see.
Yeah, and if that underlying membrane is inflamed, say, from an infected, swollen appendix contracting those core muscles right against it, will cause localized severe pain.
Wow.
So the 8-year-old didn't just have the family virus. He had acute appendicitis and actually ended up having his appendix surgically removed that weekend.
Diagnosing based entirely on local outbreaks is, honestly, it's like searching for your lost keys only under the streetlight just because the light is better there.
Yeah, it's a great way to put it.
You have to actually examine the dark terrain. You can't just say, well, there's a lot of the stomach bug going around until you've actually put hands on the patient.
And that anchoring bias, getting mentally stuck on that initial easy assumption, it happens all the time with a patient's past medical history, too.
Oh, for sure.
Case 4 illustrates this beautifully. So a 30-year-old woman comes in with right iliac fossa pain.
Which means pain in her lower right abdomen, right?
Exactly.
And looking at her chart, she has a long, well-documented history of pelvic inflammatory disease, or PID, and recurrent urinary tract infections.
Yeah, and plus her urinalysis shows a trace of blood right there in the clinic.
So if you're a medical student listening to this, the neon sign in your brain is flashing UTI or PID flare-up.
It absolutely is.
Yeah.
But you really have to look at the other, much subtler clues here. She mentions she hasn't had a period for 40 days.
Okay, that's a clue.
Though she has experienced some, like light spotting, she feels faint, her breasts are tender.
Right.
The clinician decides to perform a routine urine pregnancy test, and it comes back positive.
Wow.
And suddenly, that routine lower right abdominal pain transforms from an infection into a massive, life-threatening red flag.
Because we are now looking at an ectopic pregnancy,
Precisely.
a fertilized egg that hasn't made it all the way to the uterus and has basically implanted inside the fallopian tube.
Yes. And her specific medical history of PID actually increases her risk for this.
Wait, really? How?
Well, pelvic inflammatory disease leaves scar tissue in the fallopian tubes, which makes it a lot harder for the egg to travel normally.
Oh, that makes sense.
And if that tube ruptures, she could literally bleed to death internally within a matter of hours.
So the physical exam here has to be incredibly gentle, right? You don't want to be the one to press down and accidentally cause that rupture.
Absolutely not. No deep palpation whatsoever. They rushed her for an urgent ultrasound to confirm the ectopic pregnancy, followed by a life-saving laparoscopy.
Which is that minimally invasive surgery, right? Where they insert a tiny camera and instruments through small incisions in the abdomen to locate and safely remove the ectopic tissue before it bursts.
Exactly. If the doctor had anchored to her history of UTIs and just, handed her a prescription for antibiotics, she easily could have died at home.
That is terrifying. So both of those cases were acute emergencies. But I'm looking at case 3 here, which deals with chronic, nonspecific abdominal pain.
Yeah, this is a tricky one.
We have a 22-year-old ceramic student, thin, highly anxious. He's had mid-zone abdominal pain and diarrhea for months.
Months of just feeling awful.
Yeah, and if I'm the doctor here, my brain immediately goes to his environment, right? Like, is he inhaling toxic ceramic glazes? Is it just stress from his notoriously anxious family? Or I think the text mentioned our recent trip to Tanzania.
It did, yeah. So you might think of a tropical infection.
Exactly. So how does a doctor cut through months of chronic noise to find the actual signal?
Basically, by not letting the patient's lifestyle distract from the actual clinical data.
Right.
The doctor ordered a specific blood panel, and the true diagnosis was celiac disease. His endomysial antibodies were just off the charts.
Okay, let me stop you there and just define that for our listeners. So endomysial antibodies are specific autoimmune markers. When a person with celiac disease eats gluten, their immune system basically panics and attacks their own tissue, specifically the villi, those tiny finger-like projections lining the small intestine.
Perfect explanation.
So those antibodies are kind of the smoking gun of that internal attack. But I do have to push back here for a second.
Sure.
Isn't celiac disease heavily covered in medical school? Like, why is it so vastly underdiagnosed in general practice?
That's a great question. It is heavily covered, but it's often taught with a really outdated clinical picture.
What do you mean?
Well, we're trained to look for severe weight loss, emaciation, and profound malnutrition. But the reality today is most patients with celiac disease are of normal weight.
Oh, really?
Yeah, or even overweight when they present. There are symptoms like bloating, mild pain, occasional diarrhea, tiredness. They perfectly mimic irritable bowel syndrome.
Wow, so it just gets written off as IBS.
Exactly. The textbook picture of the severely emaciated patient is quite rare today. So it requires a clinician to maintain a really high index of suspicion to actually, tick the box for that specific antibody test on the lab form.
So the physical exam and the patient's history can actively lie to you or at least heavily mislead you.
Oh, definitely.
But as a clinician, you might think, well, I can always trust the lab results, right? Blood doesn't lie. But looking at case 6, we see that lab results can actually be the biggest red herring of all.
Yes. This case is just a fascinating intersection of physiology and administrative protocol.
Okay, set the scene for us.
So we have a 25-year-old pregnant woman. Her routine blood work shows a microcytic hypochromic anemia.
Which, in plain English, means her red blood cells are abnormally small and pale.
Right. So the nurse practitioner sees this, assumes she is iron deficient,
Right.
which, by the way, makes complete sense. Pregnant women are notoriously iron deficient because their blood volume is massively expanding.
Sure, they're growing a human.
Exactly.
Right.
So she prescribes iron tablets.
Yeah.
But 4 weeks later, her hemoglobin has actually dropped further The iron did absolutely nothing
Wait, why?
because she wasn't iron deficient. She was a carrier for beta thalassemia, which is a genetic blood disorder.
Oh, wow.
And the crucial distinguishing factor was sitting right there in her initial lab results, specifically in her erythrocyte, or red blood cell count.
Okay, walk us through that. How does the count tell you the difference?
So in iron deficiency, your body literally lacks the raw building blocks to make red blood cells, so your overall red blood cell count goes down.
That makes sense. But with beta thalassemia.
Well, the body has plenty of iron, but the genetic blueprint for hemoglobin is defective. So the bone marrow detects that the hemoglobin is faulty and kind of panics. It frantically churns out more and more of these flawed, tiny red blood cells trying to compensate.
Oh, I see.
Yeah, so a thalassemia carrier will actually have an increased red blood cell count, even though the cells themselves are small and pale.
Okay, acting as the questioning medical student here.
Bring it on.
If a low hemoglobin measure in a pregnant patient is supposed to automatically trigger a genetic screening for blood disorders, why was she just good in iron initially? Why didn't the lab run the specific genetic test the very first time?
Honestly, because of a simple administrative error that highlights the messy reality of clinical practice.
Really? Just an error.
Yeah, the initial nurse likely failed to write pregnant in the clinical details section of the lab request form.
Oh my God.
Yep, the lab technician just saw a low hemoglobin count in a random adult female and applied the most statistically likely algorithm, which is iron deficiency.
That is wild.
Only on the second test, when the nurse explicitly noted the pregnancy and the total failure of the iron therapy, did the lab actually run the hemoglobin electrophoresis that caught the thalassemia.
Which is a massive deal, right? Because hemoglobinopathies are recessive genetic traits. If she's a carrier, they urgently need to test her partner.
Urgently, yes.
Because if he is also a carrier, the fetus has a 1 in 4 chance of being born with severe, potentially life-threatening anemia.
It's a profound lesson. A lab result is truly only as good as the clinical context you provide to the laboratory.
Context is everything. Which leads us perfectly to case 9, where the symptom itself basically defies normal context.
This one is intense.
Yeah, a 6-year-old woman presents with excruciating burning pain in her left arm. The whole arm feels hot, it looks mottled, and it's so incredibly sensitive to touch that she actually wears a cotton vest specifically to stop her wool cardigans from brushing against her skin.
Which just sounds agonizing.
Truly. And the obvious traps here are assuming it's shingles because that causes severe burning nerve pain or maybe lingering trauma. Because looking at her chart, she fractured that exact same wrist 6 months ago.
But the clinician here steps back and looks at the mechanisms.
Right.
She doesn't have a rash, which strongly rules out shingles. The fracture healed perfectly 6 months ago, so the bone is totally fine. And the mottled skin and the physical swelling, they just don't fit the profile of nerve pain.
So what does the doctor do?
The doctor trusts her unease, rejects the easy answers, and refers the patient for an urgent vascular scan. And the surprising diagnosis,
Yeah.
an axillary vein thrombosis,
Yeah.
a massive blood clot in the main vein of her arm.
You almost always hear about deep vein thrombosis in the legs, like after a long flight. You rarely ever hear about it in the arm.
It is super rare.
Hmm.
But she required immediate hospitalization and blood thinners. Because the mechanism of a clot is the same anywhere. If a piece of that clot breaks off, it travels straight to the lungs, causing a pulmonary embolism.
Which is often fatal.
Exactly. The big takeaway is that when symptoms don't fit the physiological mechanisms of the expected pattern, you cannot just force them into a convenient diagnostic box.
Wow. So we've been talking a lot about these single acute vascular or blood issues. But stepping into geriatric medicine, you are rarely dealing with just one problem.
Oh, almost never.
Right. In the elderly, patients often endure symptoms for years, and they present with this tangled web of concurrent pathologies.
Case 11 is an absolute masterclass in this.
Yeah, let's get into it.
So we have an 83-year-old man who hasn't seen a doctor in years. He comes in with a laundry list of issues. Severe back pain, having to pee constantly, reduced urinary flow, sky-high blood pressure at 187/96.
That's high.
Yeah, and a routine blood test shows hypokalemia, which means very low potassium.
Okay, when a patient dumps a list of symptoms like that onto your desk in a 10-minute appointment, how do you even sequence the tests? Like, where do you start?
Well, you must prioritize ruling out the immediate, life-threatening conditions first.
Heck, which would be what here?
Back pain, combined with urinary symptoms, and an 83-year-old man screams one major thing. Prostate cancer that has metastasized or spread to the spine.
Oh, because the spinal tumor causes the back pain and compresses the nerves controlling the bladder.
Precisely. So step 1 is a PSA blood test to check the prostate and an X-ray of the lumbar spine.
Okay, let's say those come back clear. No cancer.
Yeah.
What next?
Then you start unpacking the multiple benign pathologies. The urinary symptoms are highly likely to be benign prostatic hypertrophy, a non-cancerous enlarged prostate that just squeezes the urethra, which is incredibly common at his age.
Right.
The high blood pressure could just be standard essential hypertension. But remember that low potassium?
Yeah, the hypokalemia.
That requires explaining. You can't just ignore a weird lab value.
So what causes that?
It brings up a rare but vital differential diagnosis, Conn syndrome. This is a condition where a small tumor on the adrenal glands pumps out way too much of a hormone called aldosterone. Aldosterone forces the kidneys to hold on to sodium, which drives blood pressure dangerously high, and trade it for potassium, which just gets dumped in the urine.
Oh, wow.
Yeah, and that potassium loss perfectly explains his muscle weakness. So you have to test his renin and aldosterone levels to confirm.
It really shows why you can never treat a single symptom in isolation in older adults. Everything is connected.
Absolutely everything.
Speaking of back pain, I want to look at case 12. A 65-year-old freelance journalist comes in with an acute lumbar disc herniation. Back pain is kind of the bread and butter of general practice, but the text emphasizes these critical red flag symptoms that every clinician must memorize to prevent permanent neurological damage.
Yes, because a herniated disc, where the soft jelly inside the spinal disc basically pushes out, can press on the cauda equina.
And that's the bundle of spinal nerves at the very base of the spine.
Yeah. Exactly. If a patient with back pain reports saddle sensory disturbance, meaning numbness in the areas that would, touch a saddle like the buttocks or perineum, or any sphincter disturbance like urinary incontinence or retention, that is cauda equina syndrome.
Because the nerves controlling those vital functions are actively being crushed.
Yes.
So how do you test for that quickly in the clinic?
You test specific dermatomes. Dermatomes are areas of the skin that are directly wired to specific spinal nerves.
Okay.
You ask them, can they squat? Can they walk on their heels or their tiptoes? If they can't perform those specific motor functions, it means those specific nerves are dying.
Wow.
It requires urgent neurosurgical decompression immediately. You do not wait.
It's terrifying how fast things can turn. But sometimes the danger is that the terrifying symptom just vanishes, making the patient think they are perfectly fine.
This happens all the time.
Case 32 outlines a 73-year-old man who experiences slurred speech and facial weakness. But by the time he finally gets to the doctor, it has completely resolved. He feels, quote, back to normal. And he actually doesn't understand why his wife made him come in.
And this is one of the most dangerous moments in clinical practice. The patient feels fine, so they just want to go home. But those transient symptoms are the absolute hallmark of a TIA, a transient ischemic attack, often called a mini-stroke.
Think of it like a rock temporarily blocking a garden hose, right?
Yeah.
The pressure builds up behind it, the water stops flowing, but then the pressure forces the rock to just shoot out, and the water flows normally again.
That is a brilliant analogy.
The garden is perfectly fine for now, but it proves that your water supply is full of rocks.
Exactly. A small blood clot temporarily blocked blood flow to his brain, causing the slurred speech, and then it cleared. But it is a massive warning shot.
Yeah.
If he isn't urgently referred to a specialist unit to manage his risk factors, getting his blood pressure down, prescribing blood thinners, he is at an incredibly high risk of a massive, permanent, paralyzing stroke in the coming days.
Wow.
The clinician really has to advocate forcefully for the patient's future safety, even when the patient feels perfectly healthy in the present.
Advocating like that requires immense trust between the doctor and the patient. And that trust is really the foundation of our final overarching concept today.
Yes, the psychosocial iceberg.
We're moving from purely physiological puzzles to cases where the physical symptom is literally just a ticket into the room, and the true pathology is social or psychological.
These are the cases that truly define the art of general practice. Take case 5. A 15-year-old boy comes in with his mother for a consultation about mild acne.
Pretty standard stuff.
Right. But the doctor intuitively asks the mother to step out. Once they are alone, a gentle conversation reveals the acne is barely the issue. The boy is using this minor physical complaint to get into a safe room to ask for help.
He's under severe psychological stress. He's clashing terribly with his demanding, highly successful father over his lifestyle and his love for drum and bass music.
Yeah, the father expects a classical musician.
And the boy is just spiraling into depression.
If the doctor just writes a prescription for a topical acne cream and opens the door, they have entirely failed the patient. The true diagnosis isn't a dermatological issue. It's a family system in severe distress and a teenager at risk.
We see that same need to treat the context in case 8-2. A 30-year-old truck driver tears a muscle in his arm. Medically speaking, the treatment is incredibly simple. Non-steroidal anti-inflammatories, ice packs, and rest.
Very straightforward.
But the clinical application of that treatment is vastly more complex.
Because you have to look at what rest actually means for him in the real world. He drives a heavy articulated lorry. He has 4 young kids, including a 4-month-old baby.
Wow. Okay.
He relies entirely on his physical labor to feed his family, and he has no financial safety net. Resting his arm isn't just a medical directive for him, it is a full-on financial crisis.
Right. He can't safely drive a massive truck. But if he's sitting at home, he's going to be picking up the crying baby to help his exhausted wife, so the arm won't heal anyway.
Exactly. The GP has to coordinate a plan for his financial, social, and mental well-being during recovery, keeping a really close eye out for depression as this traditionally tough provider sits idle.
And sometimes the physical and psychological merge in incredibly dangerous ways. Look at case 100, a 15-year-old girl whose BMI drops to 17. She is pale. She is passing huge amounts of glucose in her urine, and she is passing ketones.
The red flags are everywhere on this one.
Let's define ketones quickly. When your body can't process glucose for energy, it starts frantically burning fat instead. Ketones are the acidic byproduct of that fat burning.
Exactly. So the physical diagnosis here is clear. Type 1 diabetes. Her pancreas just isn't producing insulin, but the treatment is complicated by a severe psychological layer. It's a phenomenon called diabulimia.
Yeah. She discovers that if she intentionally skips her life-saving insulin injections, her body cannot absorb sugar into her cells.
Right.
So she just urinates the calories away and loses weight rapidly.
Which is terrifying because she is risking fatal diabetic ketoacidosis, where her blood becomes literally too acidic to sustain life just to stay thin. You cannot just hand this patient a vial of insulin and a syringe and explain the dosing schedule. You are treating a lethal metabolic crisis wrapped inside a severe eating disorder.
That's incredibly complex.
It is. It requires a massive multidisciplinary approach involving psychiatrists, dietitians, and endocrinologists.
It really brings to life a quote from the book's preface by Dr. McWhinney. He wrote, "A patient's illness or disability became interwoven with a life story."
That's beautifully said.
But let me ask you, how on earth does a clinician balance the pressure of a strictly timed 10-minute appointment with the need to uncover these deep, complex psychosocial roots?
It is honestly the great tension of modern medicine, but the answer lies in continuity of care.
Okay, meaning what?
You do not have to solve the whole life story in one 10-minute slot. You use that first appointment to establish trust, address the immediate physical safety, and then you say, I want to see you again next week for a double appointment.
Ah, I see.
You build the picture over time. The ultimate diagnostic tool isn't the stethoscope, and it isn't the lab report. It's the relationship itself.
That is just beautifully put. Well, as promised for our listeners who love to test their knowledge, it is time for our clinical review exercise. Let's test your recall from earlier in this deep dive. Are you ready?
I'm ready.
Here's the question for you listening. If a pregnant patient presents with microcytic, hypochromic anemia, small, pale, red blood cells that does not respond to iron therapy, and her erythrocyte count is elevated, what specific genetic condition should you immediately screen her and her partner for?
Take a second.
If you said beta thalassemia, you absolutely nailed it. The elevated red blood cell count caused by the bone marrow trying to compensate for defective hemoglobin is the clinical giveaway.
Excellent recall if you got that.
So we've explored the deception of the physical exam, the traps hidden in lab results, the tangled web of geriatrics, and the profound depth of the psychosocial iceberg. It leaves me with a final provocative thought to mull over.
Oh, well, let's hear it.
We hear constantly today about how artificial intelligence is going to revolutionize medicine. And sure, an AI can process a diagnostic algorithm or flag a low hemoglobin lab result in a millisecond.
It is completely unparalleled at data processing.
But reading this casebook proves something else entirely. The most irreplaceable skill of a clinician isn't data processing, it is human intuition.
Absolutely.
An algorithm might look at a 15-year-old boy's skin, process the visual data, and output a prescription for acne cream. It takes a human to look at his posture, hear the hesitation in his voice, understand the context of his family dynamic, and realize the real diagnosis is a cry for help.
That's it right there. An algorithm sees the data points.
Yeah.
A human sees the context.
So the next time you are faced with a complex problem, medical or otherwise, remember that the obvious data doesn't always show the whole picture. Sometimes the real answer isn't in the numbers, it's in the life story. Thanks for joining us on this deep dive. We'll see you next time.